Today's topic is otosclerosis. So, what is this? This is hearing aid that can be used in otosclerosis. Otosclerosis is the disease of otic capsule. Otic capsule is invagination of ectoderm in the fetal life. So, this otic capsule is formed of ectoderm. So it is primary disease of otic capsule. There is bony labyrinth and membranous labyrinth. So it is the disease of bony labyrinth that include cochlea. So dense mature bone converted into spongy immature bone. So that is immature bone is more vascular. So objective of this lecture is that by the end of this lecture we will solve this scenario. So etiology of this disease is unknown. Recall the anatomy of the middle ear, tympanic membrane, ossicles, and the last limit is the foot plate of stapes. So this foot plate of anterior part of foot plate of stapes is the primary site of involvement of otosclerosis. So this bone is converted into immature bone. So incidence is 0.5 to 1%, commonly seen in white races. Uh, Females are more affected, but in Asian, males are more affected. Age limit is 11 to 30 years. Familial, it is familial disease, autosomal dominant disease, and is seen in 70% of the cases. So it is theoretically it is related to estrogen hormones because it is commonly seen in female. So theoretically it is related to estrogen, and the disease aggravates during pregnancy. So that's why we think that it is related to estrogen hormone. So stress and trauma also aggravate this condition. So sometimes it is associated with accidents, major operations. So it is also seen in osteogenesis imperfecta, that is also familial disease. So what is the site of involvement in cases of otosclerosis? I have told you anterior part of foot plate of stapes. Foot plate of stapes cover the oval window. Anterior part is called fistula antifenestratum. So anterior part is involved, then posterior part, that is post fenestratum, is also involved in by the disease. So sometimes round window is involved. If cochlea is involved, so there will be sensorineural hearing loss. If semicircular canals are involved, then there will be vertigo, and then petrosquamous suture can get involved by the disease. Sometimes base of styloid process is also involved by the disease. So it is the disease of temporal bone. It is not seen outside the temporal bone. It is only a disease of the temporal bone, and the thick normal mature bone is converted into immature spongy bone. So it is as the name indicate. Name is according to the name of otosclerosis means sclerosed bone, but it is not the sclerosed bone. It is spongy bone. So recall the anatomy again. This is the foot plate of stapes, and it is involved by otosclerosis, and mature bone is converted into immature bone. Immature bone is vascular, having more blood supply. You can see in this oval window, then round window, then cochlea and semicircular canals. All this can be involved by the disease, but the main site is foot plate of stapes. So stapedial otosclerosis involving the foot plate of stapes, cochlear otosclerosis involving the cochlea, causing sensorineural hearing loss. So it is progressive disease. So as the time passes, it can involve cochlea and as well the so and the semicircular canal as well. Dense bone of otosclerosis with unstable cartilage is replaced by spongy bone instead of compact normal bone. So histopathology. So red chalky white in color. It is red chalky white in color. Numerous marrow and vascular spaces are seen in this canal, in this immature bone, and it stains blue with hematoxylin and eosin stain. So because of it is immature bone, highly vascular bone, so plenty of osteoblast and osteoclasts are seen. There is resorption of the bone and deposition by the immature bone. Resorption of mature bone and deposition by the immature bone. So this is the histopathology. So how will you diagnose the case? As the diagnosis depends on clinical features, investigations, and then you will treat the patient. So first symptom will be deafness. Deafness is usually bilateral, progressive, and conductive hearing loss when there is tapegial otosclerosis. If there is involvement of the cochlea, then there will be sensorineural ailment. So in majority of the cases, there will be mixed hearing loss. Conductive element is always present in otosclerosis, so Renes will always be negative in these cases. So paracusis villi, patient will hear better in noisy places as compared to quiet places. So this phenomena is called paracusis villi, because in noisy places normal person will increase his voice, will increase the intensity of his voice. So if patient is not hearing background noises, he will hear better in this condition. So tinnitus, when there is involvement of the cochlea, is seen in 80% of the cases. Tinnitus is usually low pitch and resemble the sound of some machine. So if there is involvement of the semicircular canals, there will be vertigo. It is the secondary endolymphatic height drop secondary to otosclerosis. In Meniere's disease, there is primary endolymphatic height drop with unknown etiology. But in this etiology is known etiology is otosclerosis. So symptoms may resemble Meniere's disease. So you have to include otosclerosis while discussing the differential diagnosis of Meniere's disease. So the signs, what are the signs? If there is active disease, immature bone is more vascular. So you can see pink hue, pink color through the tympanic membrane. That is called flamingo tint or short sign, just over the foot plate of stapes. That is, and reflection of this red discoloration can be seen through tympanic membrane. Eustachian tube functions will be normal. Tuning fork test, Renes will be negative, indicating conductive hearing loss, and Weber will be lateralized towards the conductive hearing loss or towards the better ear. If there is bilateral disease and in one ear there is more sensorineural hearing loss, so Weber will be lateralized towards the better ear where there is less sensorineural hearing loss. So investigation, you will advise pure tone audiometry. So car head notch is seen. Car head notch is dip in the bone conduction that is seen at the level of 2000 hertz. This dip is because of the fixation of foot plate of stapes, because some when you put that when you are giving stimulation over the mastoid process, some waves pass through the foot plate of stapes. So if there is fixation of foot plate of stapes, so there is dip in the bone conduction at the level of 2000 hertz. This is the Carhart notch. So mostly there is mixed hearing loss if patient is if there is involvement of the cochlea. ABC will be reduced and Weber will be lateralized towards the ear where there is less sensorineural hearing loss. So normal speech discrimination, because there is no nerve involvement, so speech discrimination will be normal. So tympanometry, when you will advise tympanometry you will advise tympanometry, there will be decreased compliance because there is increased resistance of the ossicles due to fixation. So compliance will be less, and stapedial reflex will be absent. So investigation, HRCT can be advised to show immature, to show the HRCT will show the immature bone, and tympanometry, tympanotomy is the will give 100% uh, diagnosis. On the table you will raise the tympanomeatal flap and you will palpate the ossicles, and you can see fixation of foot plate of stapes by direct palpation of the ossicle. To revise something, this is normal audiogram. There is conductive hearing loss showing earbone gap. This is sensorineural hearing loss. Both graph are um, below normal, so it is, and overlapping each other, so it is sensorineural hearing loss. So differential diagnosis: tympanosclerosis, adhesive otitis media, congenital fixation of foot plate of stapes, dislocation of ossicles, serous otitis media, and Mcqs disease and acoustic neuroma. You should include these disease also. So how will you differentiate it with tympanosclerosis? Tympanometry will show low compliance in tympanosclerosis, but tympanic membrane will not be normal, and eustachian tube will be blocked. In adhesive otitis media, otoscopy will show fixed tympanic membrane and will show immobile tympanic membrane with chalky discoloration in both type. Then there is also eustachian tube blockage. Congenital fixation, all the findings will be same, but hearing loss will be, patient will present early, and there will be congenital hearing loss since after the birth. So dislocation of ossicles, tympanometry will show high compliance. Serous otitis media type B graph will be seen, and also the otoscopic findings will confirm serous otitis media. In case of acoustic neuroma, there will be sensorineural hearing loss, progressive sensorineural hearing loss, tinnitus, and usually seen in unilateral ear. Then in cases of Meniere disease, there will be triad of symptoms, and with vertigo, tinnitus, and hearing loss, and it will come in attack. Tympanic membrane will be normal. Tympanometry will be normal in both diseases. So treatment, medical treatment, if there is short sign, sodium fluoride can be given. There are different side effects of sodium fluoride. So if patient is not willing for surgery, we can advise hearing aid. We should counsel the patient about, because hearing loss is progressive, and the ultimate result will be complete hearing loss. So hearing aid will help in improving the quality of life, but ultimate there will be no hearing at all. So patient after that patient can be advised to take help with cochlear implant. So surgical treatment: stapedectomy and stapedotomy. In this today's we do stapedotomy. We will make a hole in the foot plate of stapes and we apply some prosthesis. This is called Teflon piston. So we will remove the superstructure of the stapes and we will make hole in the foot plate of stapes, and this Teflon piston will be attached to the long process of incus, and one side will be inserted in the hole. So it is called Teflon piston. So patient will hear normal. Uh, Hearing will be better after this surgery, but disease is progressive. So last, patient can be advised to cochlear implant if there is complete profound hearing loss. So this is hearing aid, different parts of hearing aid. So question is 35 years old lady presented to ENT department with history of deafness tinnitus in right ear for the last 5 years. She noticed it during her first pregnancy. Deafness was increasing progressively. Now she is developing same problem in her left ear. There is history of hearing loss in her mother. What is most probable diagnosis? What are the differential diagnoses, and what is the treatment? So, diagnosis is otosclerosis, differential diagnosis, tympanosclerosis, adhesive otitis media, secretory otitis media, acoustic neuroma, Meniere's disease, and ossicular chain discontinuity. So, treatment options are medical treatment and surgical treatment. Medical treatment is hearing aid, sodium fluoride if there is short sign, and surgical treatment is tracheotomy with Teflon